paper came about because after the Allergan recall on July 24th, I was getting a lot of questions from people. What the heck do we do with these patients? Do they need their capsules out? Do they need their implants out? What does a recall mean? So I contacted Mindy and Caroline Glicksman and Bill Adams and Anand Deva, and because there's nothing in the literature to really direct anything, we looked what we could in the literature and then used our own experience to come up with the recommendations we put in this paper. Mindy, anything to add to that?
No, I think that's really clear, and I think as well as referred to it with patients, even as recently as today, because of questions and concerns. And it's just nice to have an algorithm. We have a great algorithm to evaluate ALCL and how to work that up. This is a nice algorithm to use for asymptomatic patients.
Yeah, and we'll say that this could change at any point. As I said, none
Absolutely.
of this is written in stone. This is an unusual disease. We all have to take our own personal experience and our patients' concerns. Our patients, each clinical situation is different. So we're not saying that this is set in stone or what you have to do on every patient, but this is a basic guideline of where to start on when these patients came in, especially when we were having the hysteria in the weeks afterwards. And then when the letters came out from Allergan to the patients, we got a lot of phone calls. It was we thought it would be a good way to at least give people an idea. And we're happy if anybody disagrees with us as well. I don't think this is a black or white, obvious which way to go on patients like this. So we want to start running through questions. Rob, anything you want to add?
Yeah, I read through the paper as everybody has, and I agree with you. Your personal experience dictates a lot of what you're trying to do. Could each of you kind of comment on, it's not a difficult patient, but when you have a patient who's very, very adamant about a prophylactic capsulectomy, partial, complete, precise, however we describe it, in somebody who's asymptomatic, how do y'all approach those? Because those are the most difficult patients right now for us to deal with, in my mind.
Yeah, I think the first thing you have to do is acknowledge they have a legitimate concern. I don't tell my patients, I could see why this would be frightening to you and why you want your implants out right away. But let's step back, look at the whole picture, and then go from there. I've had a lot of patients come in who were adamant, I want these implants out tomorrow. I know I'm going to end up with this because everybody in my family gets crazy things. And on those patients, you have to step back and look at the whole picture. And the thing that has worked best for me to kind of diffuse the whole hysteria is, the risk right now, and again, that could change any minute, looks like it's about 1 in 2,000 for breast implant associated ALCL in patients with a macro textured or type 3 or type 4 implant. And for those patients, I tell them there's a 99.9% chance that you will not get breast implant associated ALCL with your implants. And for a lot of them, that seems to calm them down. I will say, if there are 6 million women who have textured implants in the United States and they all had their implants removed, 5,995,000 would be having unnecessary surgery. And there's not insignificant consequences and risks to surgery in general. Then start talking about, okay, here's what the risk is. Here's how you know if you develop breast implant associated ALCL. It's not like you wake up one day, the tumor will have spread everywhere. There are signs and symptoms to look for. And if you know those things and come in to get caught early, then it's a very treatable disease. But a lot of them say, I don't want to wait to see if I get it. And then if they do that, then you talk about their options and the risks involved in each one.
And Rob, I think too, and this is the same with our breast implant illness patients, it kind of also starts with the education of not all capsules are the same. And many of these women who are coming in, I've had several who come in who they're walking around with grade 3 capsular contractures. I want to get those capsules out anyway. But you explain to them, yeah, that's a capsule we want to remove anyway. That's one we want to take out. Myself, I have in BioCell implants with grade 1 to 2 capsules. And when it comes time to change my implants, am I going to get capsulectomy? I'm not sure I am. Pat and I have talked about the risk of capsulectomy is higher, and there are bad things that happen with capsulectomy. And again, just because I have a capsulectomy, does that reset my risk to zero? We don't necessarily know that it does. So I'm always going to have to watch. And once I have that conversation, like I said, I have the benefit that I have biocell implants in, and when they see I'm not running screaming with my hair on fire, it resets the conversation, and they listen, and they can talk about all the different steps and what's best for them. And I have the same conversation. I still have patients who want saline implants because they're afraid of silicone. If it's going to keep you awake at night, then that's a good reason to pursue the surgery.
Yeah, I think the first thing that the patients have to know is, do I need my implants out? No, the FDA is not recommending women have their implants removed. And that's one thing, they see recall and they think it's like the car has to go in and get the part removed and a new one placed. So that's the first thing to tell people. You do not have to do this. You don't have to do it. It's not an emergency. I did hear today that Allergan initially had put a 2-year from July 4th, 2019 kind of expiration date on the biocell warranty, where they will exchange from texture that give them the smooth implants. They've now made that indefinite. So
wow,
I think
that's great.
it's a good move on their part, so that patients aren't rushing. Because I've had patients come in now and say, I got to do this before the 2 years is up. And I think it was a smart move on their part, and it may give patients a chance to think so they don't have this time crunch on them. So the number one thing is, no, you do not have to have your implants removed. We can watch you. Mindy and I both have high resolution ultrasound in our office, which is another way that very easily diffuses these patients.
Great communication tool.
Yeah.
Unbelievable communication tool.
Yeah, you're not just saying everything is okay. I can show them, here's the wall of your implant, here's the capsule. There's no fluid between the implant and the capsule. So that kind of calms them down, that first sign of this is fluid. And if we don't see any fluid, for a lot of them, that kind of diffuses the situation too.
Okay, before we start getting questions, just since you brought up the recall, I'm sure, surgeons in varying degrees of years in practice have fielded a bunch of questions. Just go ahead and clarify what the recall was specifically, and then we'll move on to a discussion.
Yeah, for Allergan, it was a type 3 recall, which is a relatively urgent recall that there is potential harm by the devices. It's a regulatory term. It does not mean, as I said before, that the implants are recalled, that they have to be removed. They're recalled from physicians' offices, from operating rooms, from surgery centers. Shipments were stopped, and no new implants will be sent.
Okay. We're going to start with the questions, and we had received Dr. Swanson's in advance, so I'm going to read it verbatim. In view of the lack of any evidence demonstrating a benefit for simultaneous capsulectomy at the time of implant exchange in an asymptomatic patient with textured implants, and the additional cost and morbidity which may preclude any surgery, why not recommend a simple exchange of smooth implants, a short, low-risk procedure?
Go ahead.
Just let me finish. To finish his comments, it said, to me, it's somewhat a contradiction to recommend no surgery to an asymptomatic patient with textured implants, but if the patient has surgery, the capsule must be removed. If capsule removal is obligatory, so is the surgery. That's his full question.
Rob, if you look at the frequently asked questions, 3A states exactly what his question is, which is there's no scientific data to support doing a capsulectomy if there's no malignancy or capsular contracture. As you go through the pieces of question 3, B talks about what you do if a capsulectomy is performed. C, you talk about the risk with capsulectomy. And then D addresses that if the patient decides to get the implants out because they're anxious about ALCL, and you determine to do a capsulectomy because of their anxiety, then yes, you do a capsulectomy. And you do a capsulectomy if you would do a capsulectomy anyway. But we didn't say that, and I think that is a misconception, that they're in an asymptomatic patient with a grade 1 capsule, if the patient isn't anxious and they're just wanting to change implants and they understand how they need to monitor it, we're not necessarily saying that the capsule needs to come out, but if they're anxious, then yes, that's a good reason to proceed with capsulectomy.
The other reason I think to pursue capsulectomy is that there have been cases, the smooth cases that have been reported in breast implant associated ALCL all had previous textured implants. And those patients had capsules left in place when their implants were exchanged, as far as we know. I'm not going to say that 100%, but those patients had capsules. So Plan B has to be different than Plan A. So if you're going to place an implant in, now, what's the chance of that? It's low. What are the risks of capsulectomy? Not insignificant. So I think you have to discuss that with the patient, that this would not be a guarantee that you will never get breast implant associated ALCL, because there have been patients that have exchanged their implants. We don't know what was done with the capsulectomy, but since the disease seems to form in or around the capsule, if I can safely remove the capsule at the time of removing the implant, that may be a way to lower the risk as well, but we don't know that 100%.
And if you've had a seroma, if you've had any sort of complication with that capsule, any contracture in the past, you should get it out.
I agree. That's a legitimate question.
Can you comment on, so I personally I'll comment on the capsulectomy and its safety. I mean, I've done over 2,000 free-flap breast reconstructions and several thousand implant cases, and I have 2 pneumos in all that time over about 13 years. What can you describe what each of you explains as the risks associated with capsulectomy, whether it's partial, complete, precise, whatever we're referring to it as? Because it's discussed, but it's never really clarified in the comments.
Yeah,
I'm sorry, Dr. Swanson wanted to chime in. I'm sorry. Okay. Go ahead, Dr. Swanson. Can't hear him. Can't hear him.
Hunter, can you help with Dr. Swanson?
He is unmuted. I don't know if his microphone is active, but he is definitely unmuted.
Can you chat with him, or how do we do that?
I will send him an email right now, and we'll try to get this sorted out real quick.
Okay. Well, while we talk about that, I think, Rob, again, we know as surgeons, not all capsules are created equal. And so each capsule, if it's under the muscle, carries a different risk than on top of the muscle. And if it's a grade 3 or grade 4 capsule, it's a different risk, because it actually seems easier to get those out. If the patient's really thin, you run the risk of perforating the skin. I believe both Pat and I have been made aware of a death in South America from a capsulectomy recently. There was an axillary vein, I believe, injury in Canada just recently with a capsulectomy. So they're not without risk. And again, a careful surgeon, you know that. But, you know, there's also, I mean, chronic, if you're scraping a capsule off the ribs and removing periosteum, there's risk of chronic rib pain.
Yeah, I think you have to explain to the patient what a capsule is and help them understand the anatomy, whether the implant is above or below the muscle, and what that capsulectomy is going to entail.
Accomplish.
Yeah. And what are you going to do? Is there, you know, if you're under the muscle, the patient has to understand there's a chance that could collapse your lung. Sometimes that implant is so attached to the rib. I always tell them it's like peeling wallpaper off the wall. Sometimes it comes right off. Sometimes you're going to take the underlying drywall with it, and we have to be very careful about that. Late bleeding after capsulectomy has been reported. I mean, immediate bleeding or late bleeding weeks later. I've heard of patients after total capsulectomies or partial capsulectomies having a late hematoma. So then you understand there's a chance they may have to go back to surgery for any of those potential risks. Also can cause contour irregularities to the skin. I've had indentations. You know, if you end up taking too much capsule and thinning things out, Mindy said you can blood supply issues. So the patients have to make sure they understand that.
Yes. Did we get Swanson on?
Dr. Swanson, can you try to talk again here? Yeah, we see his lips moving, but we hear nothing. If you do have anything, if your mic's not working, maybe you can throw something through the chat email. And if anybody else, I should mention, has questions and wants to ask verbally, just raise your hand. You can click raise your hand, and we'll click on you and unmute you.
So I'm going to go to the next chat question. For young plastic surgeons like Ali in his board collection period, what do you recommend from a documentation standpoint about partial versus complete capsulectomies versus just implant removal for patients anxious about potential for BIAALCL? It's a good question.
Yeah, I think there's a legitimate question that if you can't get the entire capsule out, why even take part of it out if we're worried about that for the ALCL developing from that capsule? And I think that's a very legitimate question is, you know, are we doing anything if we can't get every millimeter of capsule out? Should you do it at all? And that's the thing, we don't know. I don't know if there's been a partial capsulectomy where the patient recurred. You know, we do know that with ALCL, if you don't remove the entire capsule, if there's a chance of a recurrence. My younger partner had a patient that had a Lumera implant. He left like 1 centimeter of capsule, and his patient developed a recurrence 4 years later of her ALCL. So I don't know. The answer to that question is, you know, if a partial or if you can't do a total, should you just not do anything? It's a good question that we don't have an answer to. What I tell my patients is I will try to do a complete capsulectomy. If I cannot do that safely, I will not do it. You know, I'm not going to give you a pneumothorax for something we don't know is a benefit to you or not. But if I can remove the capsule, I think there's a psychological benefit for the patient. I have to be careful that I'm not doing it for my own, make myself feel better about it as well.
And I think documentation is the key thing here. Whatever you do, document in detail. I personally have gone back on my own patients who I took implants out of 15 years ago. I wasn't necessarily dictating what the surface texture was. The patients don't know what their old implants were. So dictate all the information you have because we don't know what's going to be important later. And if you can't safely get the capsule out, dictate where you left it and how much you left.
I have a comment from Gary Tuma. He said, like for all your cases, you need to document exactly what you did and give rationale behind decision, explain risks and benefits to the patient, like Dr. Haws alluded to. And the next is a follow-up question for Dr. Ali about the young plastic surgery question. Is there then a role for cauterizing any capsule that cannot come out safely?
Yeah, I think that's a legitimate way to deal with what's stuck on the ribs or in the intercostal space. I think it's, again, do we know that does anything? No, but potentially it could. I would also, if you can't remove the entire capsule, think about, you know, soaking that pocket with phase 1 or betadine for the biofilm.
Agreed.
I think that I did one today where it was a biocell capsule. I got the capsule out while I was taking the implant on the other side. I did soak the pocket for 5 minutes with hypochlorous acid. So
yeah, hypochlorous acid, if you don't have that, half-strength betadine for 5 minutes. That does the best we can to decontaminate that pocket.
By the way, can you hear me now?
yeah, we can hear you.
You can hear me?
Yes.
Okay, maybe we've moved on, but if I could still comment. I think you are flexible in your recommendations, but some plastic surgeons are not. They insist that the patient needs to have the capsule removed. And, you know, my point in the question, we really don't have any evidence that it provides, that it's helpful from a
No, that's what we said, yeah.
And so you have to decide, are you going to over-operate or possibly under-operate? Now, we do have a plan B. If the patient does eventually develop ALCL, it's not the end of the world. So, you know, my contention is why not just replace the implants in an asymptomatic patient, leave the capsule behind, and at least you've possibly removed the triggering stimulus. And the thing is, for a lot of patients, they won't be able to afford to have an expensive capsulectomy and pay for the tissue, because a lot of people are saying you need to send the capsular tissue off to have it analyzed, and the patient may be responsible for that. So it's not going to be helpful for the patient if you outprice the remedy, because they're not going to be able to have the surgery anyway. Plus, they've got all that morbidity associated with the capsulectomy, whereas the capsulotomy, the risk-benefit analysis becomes much more favorable if you're just taking out the implants, a 20-minute procedure.
Yeah, although I said before, the smooth cases of breast implant-associated ALCL all had previous textured implants. I guess you said they could wait and see if they develop ALCL and be treated. Most of my patients don't. If I can safely remove it, I said I'm not digging around trying to get every bit of capsule. But if I can safely remove the capsule, I think I try to. I said I may be treating my own anxieties as much as the patient, but I talk to the patients about the risk of it. Most of the patients request it. A lot of them have done research before they come in. And then as far as the pathology, we have worked out a deal with our pathologist for our cosmetic patients, for the patients who they have a cash rate that's not the $4,000 they bill to the insurance company. And I would recommend that. I do recommend if you take out any tissue from a breast, I would send it to the pathologist for medical legal reasons to document it. I do photograph capsules so the patient can see and I can see what it is. And I do always send the tissue to pathology.
What is your rate, Pat? Share with everybody what rate you've been able to negotiate so we can all go hardline our pathologists.
Yeah, we got for a just inspection of the capsule. And the other point that we make later in our paper is the patients will want CD30 testing on all capsules. And I've talked to Dr. Marshall Caden about this, and he said, in the absence of any morphological abnormalities in the cells that are seen in the capsule, there is no reason to do immunohistochemistry or CD30 testing because if there's no, now if there are abnormal cells, then that's when the pathologist would make the decision of what additional testing is done. And it's the CD30 testing now that can get expensive. So just look at a capsule under the microscope and tell us whether there's anything wrong with it, and you get a report back. Our pathologists charge $199. Some of the patients want, if you get into the breast implant illness patients, they want cultures as well, and it gets to I think around $300.
We have an additional question for Dr. Tuma. Do we have any responsibility to monitor our peers who are posting on social media about in-block section be necessary? And taking pictures of and taking the pictures of them and posting them, is this possibly feeding into some of the hysteria? So for a second, I'll comment on this real quick. So you don't need to post a picture about this because Facebook groups with 100,000 patients do this all day long. So a plastic surgeon doing this, although it doesn't seem like a good thing, and maybe we can encourage our colleagues to show some restraint in that. That ship has left the harbor a long time ago. So I'll let Pat and Mindy weigh in, but I see this all the time.
But Mindy and Fouad and I just had an editorial that'll be in the print version of ASJ next month. It's online now on the breast implants illness. How can we help? And we kind of discussed be careful about using the patient's distress as a marketing tool. Is not something I would recommend. What's happened a lot is the BI and ALCL have kind of gotten conflated, and the idea that women who are symptomatic who have implants require a non-block capsulectomy comes from the ALCL literature, where we know this is recommended. There's no indication for an on-block capsulectomy in the absence of malignancy. If you can do it, I did one today on a 30-year-old, thin capsules, but subglandular. Those are kind of easy and fun to do. But there's no indication to do it. And I think posting photos of your capsules and all, I personally would not do that. And I think it does, as you said, Rob, feed into some of the concerns and some of the misunderstandings where breast implant illness and ALCL become conflated into one thing. Mindy, anything?
Yeah, I agree. It drives me crazy, and we can't police our colleagues not to do this, but geez, it's kind of too bad.
Can along those lines, those mounting, what do you say in terms of, so these asymptomatic patients for BI-ALCL, but they're in the BII group, and you're trying to determine, between their symptoms and concerns, what to do for them. What role do you feel like biofilm plays in your decision making and helping them come to some conclusion about their implants and what's going on?
I'm not sure, where biofilm fits in on all this or what you're going to do. I mean, the breast implant illness patients want the capsule removed because they're concerned there's heavy metals in the capsule. They're concerned, there's all poisons or whatever. They may not necessarily know what those are. And, if you believe that capsular contracture is a function of bacteria, maybe not necessarily biofilms, but at some point bacteria either in a biofilm form or not, that's another reason a capsule maybe should be removed when you're treating capsular contracture. But again, that's where if you believe that biofilms are what's leading to ALCL and the jury's still out on the exact cause, as Mindy and I said before, soak your pocket with half-strength betadine or hypochlorous acid.
Yeah.
Might be a way to reduce that load before you put another implant in.
So that's a strategy that the plastic surgery community could take in exercising an option for patients instead of potentially, because not everybody who comes in wants to have that device removed, but they certainly are looking for guidance about what they can do as a means to
minimize
aesthetics.
the risk.
Yeah, and maintain aesthetics. So especially in our thinner patients with moderate to larger size implants, it's a huge deal to take everything out and leave them in almost a post-mastectomy state.
Yeah, no, that's a legitimate, sometimes taking the capsule out, you're going to be left with skin, and all of a sudden you're doing like a prepectoral reconstruction. And sometimes when you go in on these patients, even with the biocell, most of the biocells seem to have a little bit thicker capsule, which can be a little easier to take out. But if you go in and it's a translucent, wet toilet paper capsule, that you're going to destroy their pectoralis minor if they're if it's a subpectoral implant, or if they're really thin and it's subglandular, and you're going to end up essentially doing a mastectomy on them. Those are patients where I think you're probably better off to leave the capsule. And that's where he said a lot of it's clinical judgment and the relationship you have with your patient. The other thing that I offer my patients that come in and they don't know what to do, I tell them, you want to come in every month and I'll see you. We can do an ultrasound. If I'm not here, my nurse can do it, make you feel better. Tell these patients, I'll see you as often as you want. I'll tell you until you make a decision about what
Absolutely.
They know they can call if they're concerned. If they, I always tell them, if you hear something crazy on the news, don't go on the internet. Come call our nurses, call one of us. We're happy to talk to you.
Let me see if we have any new questions here. Let me see.
The other questions that, the tissue expander thing is a common one. If you're taking out a tissue expander, do you need to do a capsulectomy? And I think the answer to that is no. We only know of one case so far. It has not been published yet of a tissue expander to smooth implant that developed ALCL. And that apparently was a complicated case. I don't know the details of it, but I would not recommend, in our paper, we did not recommend a capsulectomy at the time of an implant exchange from a tissue expander.
So I don't have any new chat questions, so I'll carry on the discussion and say that I see a routinely higher number of clients who've seen the recall, who have then got online and done quote unquote research, have got into some social media groups, and then have not only concerns about VI, ALCL, breast implant illness, but then they've had implants for 10 years already, and they're concerned about, what they should be doing in that next phase of an exchange or an explant or
a lift
monitoring or whatever. So can you discuss what each of you does in that respect?
Like I said, I've certainly, because of the recall, I've had women come back in and discuss things that they've been thinking about for years. As you said, either a capsular contracture or I'm 10 years older now, I've gained 25 pounds, maybe I want my implants out, maybe I don't, maybe I want to lift. And it's just treating each patient, as the individual and addressing that with them. I think the recall letter, because my office was set up to deal with it and because we had the ultrasound, has actually helped us reconnect with patients who weren't coming in who should have been.
Good.
Yeah, I think that's an important lesson for the patients, is that we want to see you every year. I always tell them, I put something in your body that doesn't belong there. I want to make sure you don't have any problems with it. And we're seeing patients, it's been kind of interesting. I've seen patients with, 15, 18, 20-year-old implants, reconstructions from 15 years ago. And it's kind of nice to see them again. And it's nice that they're willing to come back. But individually, and a lot of them will say, I've been thinking about doing something. Like Mindy said, I'm older, I've gained weight, I went through menopause, my breasts got bigger. I've been thinking about doing something. Now it's something to do. I think the hard ones are the 29-year-old, 30-year-old who had got her implants 3 years ago. I had a patient that she's 29 years old. She got her implants when she was 26. She has a style 410 implant, and she is trying to get pregnant. And of course, her father is a big lawyer in St. Louis, and it's like, oh yeah, here we go. And she comes in and she's panicked. Fortunately, her husband's an ophthalmologist who's a smart, reasonable guy who's not panicking about this. But I think those are the difficult patients. It's easy, the patient, I've had my implants 15 years. Well, it's about time you changed them out anyway. It's a 29-year-old who now is having surgery. She didn't plan on financially, didn't plan on time off work, time whatever. I think those are hard patients to decide what to do. And that's where you really have to sit down with them and say, how much are you going to worry about this? You still have a pretty good lifespan on your implants. There's a low chance, but not a zero chance you could get this. And this patient said, she was going through infertility treatments, and she said, what, I don't want to get pregnant. Halfway through my pregnancy, my breast gets swollen. And now, which could, they could even, unrelated to their ALCL, they could get a mastitis or something, and then everybody panics. Those are the ones that are very difficult. This patient decided she wanted her implants removed. And smooth implants placed. And while we're there, I want to upsize my implants a little as well. So it's I think the older implants that have been for a while are easier conversations than that I've had my implants for 3 or 4 or 5 years. Those are much more difficult conversations to have.
We got another question, and it was along those lines, and it said, should we be doing annual follow-up on asymptomatic patients? I'll be the first person to say I see so many patients who were lost to follow-up that you better be doing annual follow-up on all your patients. That's the least you can do. And I think both Dr. Haws and Dr. McGuire have alluded to that. So I have another question here, but I hear that routinely from clients that they did not follow up. Another question is from Dr. Tuma. Do we think the FDA is going to mandate some form of surveillance for these devices, i.e. ultrasound at 8 to 10 years?
I think at the recommendations by the FDA meeting, Mindy and I were both at the FDA hearings, which was really an experience. But the recommendation of the commissioners at the end of that hearing was they thought everybody was getting their MRI at 3 years and every 2 years after that. And someone presented it would be like, $10,000 these patients would have to spend, in the first 10 years, when the majority of the time they're going to be told that they have an intact implant. So I think the recommendation of the commissioners was to change to a 5-year, at 5 years, have a screening with an ultrasound. And I don't know if it was every other year. It may not even been for another 5 years after that, unless there's some change. I think they're really, it's likely they will change to ultrasound as an initial screening with MRI as a backup or for any concerns. And I suspect that'll happen in the not too distant future.
I think they also heard us at the FDA that not all implants are created equal, and that some of these do need more frequent screening than others, or you need to start earlier with ones that have a higher rupture rate, and that there needs to be some flexibility in those recommendations.
Yeah, we have an ultrasound in our office, and I offer all of my patients free ultrasound screening every year. We don't charge their patients to do it.
Yeah,
that was the follow-up question. I think, honestly, if you're going to be doing implant-based surgery or surveillance of implant patients, you better invest in an ultrasound.
Yeah, it's one of the best investments we made.
It's just not that expensive, and my God, the amount of time it saved me with patients and ratcheted down their anxiety has been well worth it. Well worth it.
Yeah, and you get very, very adept at it very quickly. If someone's like, I have a seroma, or if I have this, I mean, it's not rocket science to do, honestly. And then you can say, if you don't if you can't clearly delineate it, you say, well, you need an MRI because I
Right.
clearly can't tell.
Exactly.
Right. I tell my patients, I'm not a radiologist. Number one, I am not looking at your breast tissue. I am only looking at your implant.
That's right.
And we have a
That's
specific consent form that says that we're not, and I tell them that I'm not a radiologist, but they look at it with you. You know, they can look at it and see what you're seeing and they understand it. I diagnosed my own patient with ALCL 8 weeks ago. She came in with 5 days of swelling in her breast, and she started on Thursday. Monday we saw, or Tuesday I saw her. In the office, I did the ultrasound, aspirated the fluid, sent it off a week after her first symptom. We had her diagnosis. 2 weeks later, she had surgery, stage 1A ALCL. And that's the way it's supposed to work. And if I had to fumble around, try and get her somewhere, get the radiologist, hope he does the right test, sends it off well, it's very useful to do.
And you hear often from people that the initial ALCL seroma can wax and wane. So by the time you get them in for an ultrasound somewhere else, it could have faded away and then comes back, and you're chasing your tail. Having it in the office is well worth it.
I want you each to comment too, because I know many of us see more complicated patients with longer histories of multiple surgeries and multiple implant procedures. And so, and anecdotally, I've seen many of those patients, and they come in very asymmetric sometimes from out of state. They relocated to Austin, and I've done ultrasounds on them and been unable to clarify their concerns about whether it's swelling or just asymmetry from a previous lift or asymmetric augmentation. And the usual story is, no, I don't have my information. I moved here from X, Y, Z. And I send those people for then formal workups because they haven't been followed. And I recently found somebody who had, of course, breast cancer from their swollen breast, and we did their mastectomies and reconstruction, and I did their case that way. But whether you figure it out or not, first and foremost, you got to take them down the path and make sure they get worked up properly, and not be more diligent about it, especially in those revision cases where you don't know their histories and they've had multiple surgeries. It can be very confusing to, especially younger plastic surgeons.
Yeah, the bottom
and Rob,
we're not radiologists, so we don't want to try and do something like that. But simple surveillance of implants and looking for seromas and all. There are a lot of different ultrasound companies out there, and it's a very worthwhile investment.
Yeah.
Everybody, this is 40 minutes for closing in on me. And again, I would like to thank Dr. McGuire, Dr. Haws, Dr. Whitfield. We've had an excellent turnout, 42 participants tonight, which is actually a record. So fantastic, and thank you again. Last question from Dr. Cindy Wu. What U.S. machine company would you recommend in ballpark? How much does it cost? And did you teach yourself how to read it, or have a RADS colleague teach you the basics? We'll close on this one, Dr. McGuire, Dr. Haws.
Yeah, I have plastic surgery imaging, which I think Mindy also has. I think it's between $16,000 and $17,000 for the machine. We had training, the company
came with it.
Yeah, they came and trained it. And then what I did was every patient that came in, whether their implants were a month old or a year old or whatever, I ultrasounded every patient that came in. So I learned what a normal implant looked like. And once you get that, I first thought I'm the most untechnical person there is. And I thought, there's no way I'm gonna be able to do this. But once you see what a normal implant looks like, you develop an ultrasound eye, where all of a sudden it becomes very easy to see. I've had no false positives on any of my patients that I've read as rupture. I've gone in, they've all been ruptured. I don't know, I guess, whether I've had false negatives unless I've operated on, but so far the patients that I've operated on where I felt the implants were intact, I've been correct so far. And it gets easier and easier the more you do it.
And it is a great tool that your nurse, your ancillary people can do. If you're operating, they can get a patient in, they can scan them. Again, it really alleviates anxiety. I have the same machine Pat has at the Aesthetic Society Breast and Body Experiences meeting in Dallas. We're actually going to have an ultrasound training with more than one vendor present. And I don't have on hand what all the different machines cost, but I think the 15 to 16,000 is a pretty median cost for them.
Well, fantastic. Well, thank you for those questions. And obviously, this is a hot topic. We had great interest tonight. There was a lot of great information presented tonight. Again, thank you, Dr. McGuire, Haws, and Whitfield. If anyone wants to review again the topic tonight, it will be registered on Radar, so you can all watch it again. And certainly, I encourage every one of you to continue to participate in these Journal Club sessions, which, by the way, will be the first Tuesday of every month. So again, thank you very much. I wish everyone a good night. And again, thank you for your time.
Thank you.
Okay.
Bye-bye.
Bye.